Welcome, dear viewers. On behalf of the iFix team, I welcome you all to iFix 2020, the first pediatric orthopedic trauma conference to be held digitally online in the year 2020, brought to you by the iFix team. The topic which I'm going to speak about today is the principles and technique of TENS nailing. My name is Dr. Swapnil Keny, and I'm a pediatric orthopedic surgeon based out of Mumbai. The first principle which you need to understand is the age of a child. Now, whenever you do TENS nailing, the age of the child has to be over 5 years. If the child is below 5 years, there are various conservative methods which are possible, either in the form of a hip spica or in the form of a Paulick's harness. We would not be discussing them because that is beyond the scope of this discussion today. The second principle is that TENS is meant for mid-diaphyseal fractures only. The reason for that is you need to understand that there are two frames which develop or which are there when you fix a fracture using the TENS or the elastic stable intramedullary nailing technique. The first or the inner frame is essentially the nails which are passed across the fracture site, which are the elastic flexible nails. They are pre-bent to a particular angle with the apex at a particular point. I will come to that later. And there has to be a good, adequate, strong, soft tissue cover from all sides which supports this construct. However, if there is a fracture which is not exactly into the metaphysis, that does not mean that you cannot use TENS nailing. You can certainly use TENS nailing, but you have to modify your technique. One way of modifying it is shown in this illustration, wherein this fracture is not at the level of the isthmus, but is above the level of the isthmus. And in this case, we have decided to have the spindle of the nail at the level of the fracture site, which is extremely important, and this gives the elastic stability to this fracture. You can clearly see in this example that the spindle is at the fracture site. This is a fracture which has got a butterfly fragment, but it is stabilized with the help of elastic nailing. And that is the final result. Similarly, if you were to have a fracture of the tibia, which is in the lower third or the lower fourth, then you will also have to use an additional or augmentatory fixation, which we call as a hybrid fixation, in combination with elastic nailing, which is usually an external fixator, or there are various other modalities which can be used. And that is the final result. The third principle is that the nails should have a diameter, that is, each nail should have a diameter which is 1/3 the diameter of the bone at the level of the isthmus. To make matters simple, the two nails should occupy 2/6 of the diameter of the bone at the fracture site. Now imagine the diameter of the bone at the level of the isthmus is 9 millimeters. In that case, you would have to use two nails of 3 millimeters each, bend them, insert them from particular points, see to it that the proximal and the distal end are at two particular points, have the apex at the fracture site, and you will get a stable fixation. Now let's look at this case. This is a fracture shaft femur treated with nails which are very, very thin. And when you treat them with nails which are so thin, then it is going to be a problem as always. So this eventually went on to implant failure and had to be treated in some other manner. The fourth principle is that you have to pre-bend the nail 3 times the diameter of the bone at the level of the isthmus. In short, the radius of curvature of the nail has to be 3 times that of the diaphyseal diameter of the bone at the fracture site. The reason for this is you need to start comparing these elastic nails to a safety pin construct. Now we all know that when a safety pin is securely closed, there are two areas or two ends which are giving it stress or tension. The topmost area is where the lock is, and the lower area is where the spring is. But what is also important is the bend which is there inherently in the safety pin, which has been given for it to have elasticity as well as stability. Elastic nails run on a very similar principle, and hence one needs to bend the nail in a particular manner, in a particular degree, which is 3 times the diameter of the bone at the fracture site to get maximum possible stability, and this will prevent it from deforming and the deforming forces to act on the nail and the bone and will prevent implant failure. What you also need to understand is that an elastic nail, when it is inserted inside a broken bone, which is bent after breaking, which has deformed, the medullary insertion is one where a relatively straight medullary canal forces the curved rod to straighten within the bone. This elastic deformation creates a bending moment within the bone, which tends to angulate the fracture site in the direction and the plane of the concavity of the rod, as the rod wants to return to its initial curved state. But this moment is counteracted by a second rod of a matched diameter and curvature, which balances the first rod with an equal but opposite moment. And hence, two intramedullary nails act to complement each other and stabilize the fracture site. This is called as a biological fixation. It is not the most rigid fixation, but is sufficiently stable against angular, translational, and torsional movements, and is associated with early formation of exuberant callus. This principle is called elastic stability. If you use the principles in most instances, especially in diaphyseal fractures, that is mid-diaphyseal fractures, you do not require any sort of an external immobilization. But you need to remember that a significant imbalance may be created if the two nails are either not equally bent, and that can cause the stronger nail to deform the bone, and hence you have to have a 6-point fixation of an elastic nail of two equal diameters inserted from diametrically opposite points and pre-bend equally of a particular length and a particular diameter. This will give you stability in all forms. If you do not use the principle, like in this case, if you see the nail is too short and the isthmus is actually not very well formed, the spiral is not very well formed at the isthmus, and this can cause problems, like in this case led to breakage, needed some other form of fixation. The apex of the bend has to be at the fracture site for the elastic nailing principle to act. If that does not happen, then the scenario may be very difficult to handle. Now let's imagine this bone which is angulated and is reduced with the form of an F tool, and the apex of the nail is the point of maximum bending, and it is at the fracture site. Only when that happens will the bone remain stable. Now this is not a mid-diaphyseal fracture, it is a lower diaphyseal fracture going almost into the distal femur. But here, when you tend to have the curvature or the apex of the nail bent at the fracture site, then you will get a good amount of stability. If you feel that rotationally it is still unstable because of the fracture geometry and not because of the nail insertion, then you can always stabilize this with the help of an external fixator. At 6 weeks, this patient did well, and that is the 4-month follow-up. The span of the nail spindle has to be across the entire fracture site, extremely important, because more the span of the spindle, the more is the stability. Now let's look at this case wherein the spindle is ending above the fracture site. This is not giving any form of stability, except for some amount of metaphyseal fixation, and this is going to cause problems. The nails have to be of the same diameter, and that is the seventh principle, because when the nails are not of the same diameter, a lot of problems can happen. Like in this case, if you see one of the nails is thicker as compared to the other, this has led to displacement of the fracture. The eighth principle is that the insertion has to be from diametrically opposite points. If it is not done in diametrically opposite points, you do not get that form of tension. The principle of elastic nailing doesn't work, and eventually it will lead to problems, displacement, and certain issues which will need to be tackled with additional surgeries. The ninth principle is that they have to have a very strong proximal and distal metaphyseal anchorage in the metaphyseal bone. And this is the advantage of using it in the pediatric bone when the density of the metaphysis is very good. But if you have an osteoporotic bone, then you should never be using a tense nailing. This is another case example where the nails are not really in the metaphysis, but they do not have a very strong hold, and this will eventually lead to problems. The last principle is that the distal tip of the nail has to be 5 millimeters beyond the insertion site. This is for two reasons. One is that if it is more than 5 millimeters, it is going to irritate the skin, muscle, and subcutaneous tissue. And if it is less than 5 millimeters, it is going to be very difficult to remove a nail. So you need to calculate this preoperatively and intraoperatively so that you can plan the seating of the nail in such a manner that it is flush to the bone, it is 5 millimeters jutting out, and at the same time it is not too pokey or not too prominent to affect the soft tissues. You can use this sort of a mallet and hammering tool, and you can have a perfect nail diameter like in this case. Nail removal also becomes easy when you keep 5 millimeters of the nail outside. If you do not keep less than 5 millimeters, it is going to be very difficult to remove the nail, and more than 5 millimeters, you can have problems like this. To counteract these problems, these particular devices are available, which can be used to cover the end of the nails. These are basically called as uh, your entry point indicators, and these, when they are placed, they act as end caps, and these end caps eventually guide you towards the nail. So the end caps are essentially the entry point indicators which you can use in cases when they are available. Now this is the technique of elastic nailing. Let's imagine that this is a mid-diaphyseal fracture, and we are going to be inserting the nails from the distal points. So two diametrically opposite points from where metaphysis the nail will be inserted. You juxtapose the nail on the bone and seat on the C-arm for two things. One is you need to see if the diameter of the nail is correct, and second, you need to see where the fracture site is so that you can bend the nail exactly at the level of that fracture site, and though that will assure you that your apex is at the fracture site. Once you're certain about the diameter of the nails and the apex of the fracture, then you can start bending them. These nails were quite thick for the distal femur, as was obvious from the juxtaposition, but these were the perfect nails. Two nails, as I said, of equal diameters, occupying almost 1/3 of the intramedullary canal. The next thing is when you load the nail, you have to see that the plane of the handle and the plane of the nail are in the straight line, in the same plane. And when they are in the same plane, essentially you will bend the nail only in one direction, the direction in which you want to. Otherwise, you may end up bending the nail in different planes and different directions, and that can be a major problem. So the plane of the bend of the nail has to be again in the plane of your handle and the plane of the distal part of the flattened part of the nail. You bend it maximum at the isthmus, then you slowly bend it proximally and distally, define where your spindle is, and once you know where your spindle is, it becomes very easy. Now, many a times you will tend to overbend the nail, and before inserting, if you feel that the nail is overbent, you can reduce the bend, you can underbend, you can counterbend the nail this way, and once that is done, you are ready for insertion. Use your straight awl first, that is going to be followed by the curved awl, and eventually you need to pass both the nails simultaneously, one after the other, reach the fracture site, and once you have reached the fracture site, you need to reduce the fracture and then pass the nails so that your apex is at the fracture site and your spindle is covering a significant area of the bone. So this is essentially the way in which the nails have to go. And this is what the final picture would look like if you were to pass the nails and if you were to imagine that the TBW wire is actually the fracture site. Now, many a times you will find that the fracture is not exactly at the isthmus, but it is above the level of the isthmus. And when that is the case, you need to have the apex of the bend at the fracture site, and you need to have the spindle higher up and not at the level of the isthmus. So in this case, I have managed to make the spindle higher so that I get a good fixation and I get a good metaphyseal fixation as well. Now, if you feel that this construct is not adequate, or if you have a fracture which is slightly higher, like a subtrochanteric fracture, you can still pass these nails, and there are a couple of techniques which you can do to consolidate the position of these nails. One of the ways is to put two apical screws at the proximal and the distal part of the spindle. And what these screws do once they're inserted is that they increase the intramedullary pressure and also cause splaying of the spindle, which gives an added stability to what a normal spindle would do. So you would do this at both the ends of the fracture, the proximal and the distal. This will cause a splaying of the nail, increase intramedullary pressure, and cause these nails to become more stable. You need to remember that these are unicortical screws and not bicortical screws. The other way of doing it is, if you do not want to do this, you can stabilize this additionally with the help of an external fixator. And this can be done not only for these kind of fractures, can be also done for mid-diaphyseal and diaphyseal fractures, which are either have a large butterfly, they are comminuted compound injuries, or if they are segmental injuries. So, to summarize my talk for today, one needs to stringently follow the principles of elastic stable intramedullary nailing. Having said that, there are a few tricks, tips, and techniques which you can also use to enhance the stability of your nail in non-ideal circumstances. Insertion of the nail, bending of the nail, sizing of the nail, cutting of the endpoints, and seating of the nail are the most important technical tips which you can use in your practice to get the maximum stability and the best results. I thank all of you for the patient listening. Thank you very much.